Precision public health is at its nascent stage, some experts mention. So going forward, what are some of the things that would help us to realize the power and the potential of health technologies and innovation? The first, the most important one is, of course, acceptance by the community. If the community doesn't accept it, whether because of ethical issues, whether because it is privacy issues, or whether or not it is technology issues for old folks like me. So acceptance is important. And we need to think of the wider community, not just young folks who are very knowledgeable with new technology, but think about across the whole, the life spectrum, and try to educate people when the opportunity arises.
During peacetime and during crisis time, being able to build up a trusting and a workable relationship with private companies, private players, it's just as important, especially when we centered it around the issue of communications. Health communications remained one of the very vital elements in combating the responses for a public health crisis.
The key influencing factor at the end of the day is economics. If we look at the data that we're capturing, how it's being used, even how it's being secured, even what data we're capturing, it's driven by economics. Most of the data we capture today is really in healthcare is really driven by the need to get reimbursed. And so how we capture, how we code it, or we have to report it for some regulatory agency. And it's actually one of the things that prevents us from being more precise. And so it's actually exciting to see things like genomic data, geospatial data, things that are not being done for regulatory purposes coming into the fray of healthcare data. But really the siloing right now is based upon economics. And so there has to be a change in the economic landscape. So at the end of the day, if the dollars aren't there, the activities are not sustainable. And that's why the dollars have to be, the economics have to be rethought to encourage the activities that we need to break down silos, to get sharing, to collect the appropriate data. And where that comes to a head, and this is going off track a little bit for here, frankly, is when we get to a value-based care system.
What I'd like to kick off with, YY, is just a little bit of a sort of background to how the life insurance, the life and health insurance industries are evolving around the world, but particularly here in Asia. In a nutshell, what the evolution is we're moving from being a reactive payer to being a proactive partner. In simple terms, rather than the age-old practice of underwriting a risk at a point in time, and then just waiting until that event happens, and in so doing triggering a payment from the insurer, we proactively manage that risk by helping our customers improve their health. In providing that access, what's unique about us is actually we fundamentally integrate this healthy behavior into our insurance product. And again, I know we'll expand on that in a while. And what it does is it produces a pure form of shared value creation. Obviously, our customers staying healthier for longer is good for them. It's good for our business, and it's good for the communities we serve. So it really is a pure form of shared value. As a leading insurer, we're evolving from being this reactive payer to proactive partner. We're moving from being transactional and a potential commodity to being service-orientated and value-adding, thus underpinning sustainable long-term value-creating growth, which everybody wants to achieve. So rather than being passive and waiting for an event to happen and then reacting, we're proactively helping our customers reduce the risk of that happening. That's true proactive risk management, which is at the core of insurance. So specifically, let's get specific now, rather than wait for someone to get ill or die and then paying, we're helping people live longer and be healthier for longer through this proprietary health and wellness platform of AIA Vitality. It's science-backed, it's proven, it's got proven efficacy in improving people's health. And I'll share the sort of programs or propositions we want to develop for our customers are ones like this. Join our program at AIA. We will half the chance of you getting cancer. But if you do get cancer, we'll double your chances of survival. Oh, and by the way, we'll pay for that treatment. Are you interested in that proposition? A very different, more compelling proposition than, look, we'll insure you if you happen to get cancer, we'll give you a payment. That's very much the way that we want to develop our proposition, really partnering people to help reduce the risk of getting ill, and then if they do get ill, helping them through that by paying for it, but making sure they get the right diagnosis, treatment, and recovery plan. So we're still a payer, but not just reactively. Importantly, we proactively partner with our customers across the health journeys of predict, prevent, diagnose, treat, and recover to help them be healthier for longer. That's simply it. That's good for them. It's good for their families. It's good for their employers. It's good for our business. It's good for economies and societies at large.
The citizens themselves, the end beneficiaries, recognize that there is this opportunity to do something differently. And rather than self-assembling and trying to develop things in this way, we recognize that enablement of the groups that already exist within a country, the ability to bring entrepreneurs together to help to catalyze some of these technologies, effectively, in some ways, reflecting back this workforce issue at the very highest end. So things like bioinformaticians or ISO certified technicians that Ben mentioned in the talk, but try to see how is it that you could build a more robust system within countries to support for oneself. And so in combination, we are finding that there are opportunities now at the highest levels to take the potentially most complex technologies, say to put genome sequencing capacity and cloud compute infrastructure in places that may not have access today, while also recognizing that a lot of the tools that we see that could really bring forward this concept around precision public health really could begin in the communities, in the lower level health systems, where people are already getting care, but ensuring that the data are flowing in a way that the decisions can still be made centrally for the population as a whole.
I think in terms of the precision public health Asia society, I think that's really important in that we do need new partnerships. If we continue to do exactly what we're doing in the same kind of configuration, we'll get much the same results. And it's a pretty unequal world when you look out there. So we need new partnerships, and perhaps COVID has given us a trigger to have those kind of new discussions and new partnerships. So I absolutely feel that part of the new partnerships is with government, actually. If you look at many of the current partnerships, they fail to include government. And part of the reason is, the academics get together and the institutions get together, but often who's not at the table is government and the policymakers. And partly going back to Andrew's first presentation, maybe our use cases are not sufficiently strong enough to bring government to the table. And I really think we need to work harder to bring government to the table always, as opposed to kind of sometimes. Otherwise, there will continue to be a technology academic enterprise without the policy change and the actual change you need.
Every country is different, both from a geographical point of view, since we talked about GIS, but more importantly, in terms of the relationships between the individual citizen vis-a-vis the government and other stakeholders in this ecosystem that we're all in. The levels of trust in public institutions is a very key consideration when we talk about public health.
The role of academia is really to provide sort of a sound conceptual framework and evidence based on research in terms of understanding the complexities of the interactions between the different components of the health system during a pandemic. So that's a traditional contribution of academia.
And so that sort of comes on to this topic of interoperability and also better data security, which is one I'm sure which will come up this morning, because a lot of it is around our own behavior and how confident we feel with providing our own data or understanding how our own data is being used. But again, through the indexes, we saw that there's some great strides in of countries that have been able to make a lot of progress when thinking around strategically, how can we set health systems up in order to be able to better share data at scale and in a meaningful way. And when we look at it from a healthcare perspective, of course, we've seen countries like Taiwan and China, where there's long-term strategies, whether it's linked to electronic health records, of being able to think around how do we create national platforms and share biomedical big data. I think it's also really important to consider the other side of that, when you can maybe have countries like India, where it's a highly federalized health system, and then they have additional obstacles to think about when maybe it's not so easy to share data across, and then how do we overcome some of those potential issues. But of course, with that, I think, from a systems point of view is one point, but of course, how do we really build this confidence? And at the same time, thinking about the opportunity that we have when there is more transparency around how the data is actually being used and collated and brought together.
But going beyond that, perhaps it is also about maybe some agreement on the nature of the data itself. What is the most relevant data that is equally useful to both public, private sector, to policymakers, to consumers, to sort of perhaps identify the idea of a minimum data set.
So far, when we talk about population health or precision health, sometimes the data sharing has been more one way than it ought to be. So very often, at least in Singapore, the doctors are required to contribute, the general practitioners as an example, data upwards into the systems if they pick up diseases and things. But we do know that for successful precision medicine, that sharing needs to be two ways. So we're also now starting to think through, to what extent can we share back some of the data that the government has with the general practitioner, so that the general practitioner, with the individual's consent, has a more holistic view of the individual and therefore better able to look after their needs.
At some point in time, and this applies to the private side of things as well as the public, what we are calling precision public health simply needs to be termed healthcare. Because the fact of the matter is, when I talk to people who are not in healthcare but are patients, they expect what we're already talking about, right? That's what the expectation is. And really, when we're not delivering precision public health care, we are failing to meet expectations of the patients in general. And that's today, that's not 5 years from now.